what are the things that we might be asked as a short note or your clinical based study, question on clinical based, or it can be a short note. Now, you see the pectoralis major muscle, the foramen of Langanger, the tail of the breast, this is the nipple, areola, mammary gland, and this is the external oblique over the rectus sheath and digitation of serratus anterior. You can see the digitation of serratus anterior. When you open, you just lift up the breast in a dissected body, you will see the serratus anterior digitation and also the pectoralis major muscle. Now, venous drainage of the mammary gland, you can see simple drawing, simple illustration. You can see the vertebra, the internal venous plexus, azygos vein, posterior intercostal vein, internal thoracic vein, and the axillary vein. The venous drainage of the mammary gland, this is very important because if there is, it's a malignant lesion in breast, then the metastasis might go into the vertebra. A patient you are treating with breast cancer, after 1 month she comes with a fractured spine. She is unable to move and she has a scoliosis. You do an X-ray, you will find the fracture of the thoracic vertebra where the venous drainage, internal venous plexus is there in the vertebra. Now, lymphatics from the parenchyma of the breast. Now, this is important. A short note on lymphatics of the breast parenchyma. Now, this is the apical group. This is the anterior group. This is the parasternal group. See, 75% of the lymphatics of the breast drain into the axillary node, 75% drain, apical and anterior group. Now, intercostal nodes 5%, this is the intercostal space. Now, the parasternal group is 20%. See the areola. Now again, lymphatics from the overlying skin of the mammary gland. The overlying skin of the mammary gland. Now the lymphatic drainage into the supraclavicular nodes, the intraclavicular node, axillary node, parasternal node, and hepatic nodes, subperitoneal lymphatics, lymph plexus, this is the rectus sheath. Now this is the ovary that actually drains through the subperitoneal lymph gland into the hepatic, into the liver metastasis, it can be in the ovary metastasis, hepatic nodes. Now, this is the embryology part of it, the mammary ridge, the accessory mammary glands and the nipple. The mammary ridge here, a streak, thin line only, but it can have, even males have this. There are two breasts. In the male I am saying, it can have a second breast, third breast in the mammary line. So this is very important. Now, triple assessment, imaging, clinical imaging, pathology, age, examination, ultrasonography, mammography, FNAC, and cord cut biopsies. Now, confidential a confident diagnosis in 99% of cases. Triple assessment of breast symptoms. Now, see, whenever you get a patient, you do an ultrasonography. Also, the sonologist, both breasts, right? It might be having a lesion or small, say, fibroadenoma, which is a non-malignant condition. Even breasts, they have fibroadenosis. It's a fibrocystic disease, very common. But you have to do an ultrasound and an FNAC, you can get diagnosed. If the FNAC doesn't give you a true picture or the thinking you are having about the clinical thinking, it does not match with you, then go for a true cut biopsy. Because FNAC only a needle is put in, the streak of tissue with the blood cells, but if there is any malignancy, you will be having malignant cells with your cells in division, and there are different stages of your mitosis. So, increase in the mitotic figures in a histopathology report, especially FNAC, but cord cut you get a more tissue. So you do a cord cut. Now confident triple assessment of breast, confident diagnosis in 90% of the cases. And also one thing that when you are examining a breast, you ask the lady to put her hands in the waist and slowly you palpate. You palpate like this. You palpate like this. You palpate like this. You palpate like this. You hold it. If you feel a nodule, if you feel any space occupying lesion, fibroadenoma, it slips between the fingers. It is also known as the breast mouse. Breast mouse, fibroadenoma. Like, see, if you see a mouse in your house, you go and chase, you put a danda or a jhata or broom, it just goes off. So when you are palpating a fibroadenoma, it slips between your fingers, that means it moves off. So you take your hand like this and palpate like this, segment wise, and then you catch hold of it, you draw a diagram like this, and in your prescription or the case sheet which will be supplied in the indoor or outdoor. If you have a page, the outdoor ticket, then you draw a diagram and also you palpate the axilla. you palpate the groups, the anterior group, the apical group, then the sternal group. If it is a malignant tumor mass, then it will be a big tumor. Also if it's a small tumor also, you palpate the abdomen, means you just palpate to see the liver. Okay, so a breast USG you order for, then you can also order for a USG whole abdomen, because the metastasis and here you can do what liver, your ovary, they metastasize if it's a malignant tumor. Now, example of accessory breast, a mediolateral oblique mammographic view of the breast demonstrates asymmetric tissue in the right axilla arrow, here the right axilla, overlying the pectoralis major, and corresponding targeted ultrasound of the right axilla shows benign tissue constant with accessory breast tissue, Polymastia. Okay. Embryologically, this is a result of incomplete regression of right mammary ridge at this location. The picture I showed you, the slide I showed you on the mammary line, male and female both have, but in the male it all descend, the mammary line, the accessory breasts, they vanish, but there can be a triple breast in the axilla. So this can be a lipoma, even it can be misleading with a lipoma or true breast tissue. So if the lady is pregnant and lactating, then there will be pain and swelling increases. But if it's a lipoma, it is soft consistency, but the diagnosis is through FNAC. Am I clear? Okay. Now you see this is the pectoralis major muscle, this is the deep fascia and deep layer of the superficial fascia. This is the breast, and this, if you do simple for any fibroadenoma, small tumors, or you want to do a lumpectomy, a big tumor mass, you can do it under local anesthesia. If you don't want to do, because in present day, the lumpectomy, only localized lumpectomy is done. Not whole breast is removed. Even if you remove the breast after all investigation, you are in a dilemma that it is a malignancy, then you remove the whole breast. Two superficial layers are present, superficial and deep layers of the superficial fascia which surround the breast parenchyma. The fascia forms septa called Cooper's ligament. Now, this is important, which attach the breast to the skin anteriorly and to the fascia of the pectoralis deep fascia. Posteriorly, they also run through the breast, providing a supportive framework between the two facial layers. If there is malignant tumors which causes infiltration and shortening of the Cooper's ligament, there will be dimpling of the skin, physical examination. Now, mediolateral oblique MLO mammographic views show Cooper's ligament, yellow arrows. This is Cooper's ligaments, which attaches the superficial layer of the superficial fascia to the skin. Also shown is the retromammary subglandular bursa or space, this white arrow, which contains loose connective tissue and additional Cooper's ligament that attach the breast to the chest wall. Now you see many women, especially urban and rural women, they usually are not in the habit of wearing a brassiere, bra. So when a patient comes with pain of the breast, mastalgia, then you ask them to wear a bra. So the lady will say, oh, tato pori na. They are wearing maxi from morning to night, and that the breast actually hangs. Now with the weight and this thing, there is a pain in the breast and the Cooper ligament. And the Cooper ligaments are supportive, as the anatomy says, and also, so you tell her, no, babu, oshude bhalo hobe na. Medicines won't work. You start practicing wearing a bra. In the morning you wear, in the afternoon you leave it, and again at 4 p.m., 5 p.m. in the evening you wear it, and in night you open it. So this is one, my personal practice. I'm sharing with you the clinical part of mastalgia, and also during menstruation, premenstrual pain of the breast occurs. Now you can see invasive ductal carcinoma in a 45-year-old woman with a lump in the left breast for 6 months. A digital mammograph clearly shows an oval shape, relatively well circumcised here. Primary mass. Breast tomosynthesis image provides better depiction of the microlobulated spiculated borders of the mass. This is spicules. A finding suggestive of malignancy. Plus you do a true cut biopsy or FNAC. If they are not conclusive, then go for a small excision of biopsy, or you remove the mass and send it for histopathology. See, in your clinical question, the question can be invasive ductal carcinoma in a 45-year-old woman with a lump in the left breast for 6 months. What will be this is the presentation. Now how will handle the case? So you would do the investigations and see these are the accessory breast. This is the breast recurrent nipple retraction, recent nipple retraction. Then pudgy orange with a duct fistula. This is a duct fistula. Now, bilateral accessory breast. See, this is the accessory breast, this is the accessory breast. This actually, you have to differentiate between the lipoma and your accessory breast. And the congenital absence of right breast, Now, papilloma of the nipple. Now, if a patient, a girl, adolescent girl, 16 years or 20 years, she comes to you with only one breast, then you initially tell her to padded breasts are available. So, wear a padded breast, a padded brassiere. bra in the short term, and also go for the investigation. Actually, you can get prosthesis, breast prosthesis. That can be you operate and place it. This is one thing. But there are some reports and disadvantages that after 20 years or something there might be some problems. So the latissimus dorsi muscle, some plastic surgeons or the plastic surgeon people, they take the latissimus dorsi muscle and put it here. They transplant and then cover it. These are that can be done for cosmetic reason, but also this thing, because but these procedures are not easily available to the common people. You have to keep in mind, I'm just saying, it is not common, but you have to keep in mind, you are not doing the operation, you are not doing this maneuver, but you refer to the plastic surgery hospital in SS camp or wherever you are located in the future. You send it. So you must have this clinical knowledge that these are the procedures that can be done. In your MBBS level, you must diagnose and give an opinion. Next, the papilloma of the nipple. This should be operated. Now you can see inflammatory carcinoma of the right breast, the inflammation, and the inflammatory breast abscess. This is the breast abscess. This is you have to give an incision and drain. Now it can be a galactocele, means a lactating mother. A lactating mother complains of the sol, lactating. Okay. Now, this will be galactocele. Galactocele. Now, you don't make an incision. You get confirmed that it is the abscess or a galactocele. Because once you the lactating mother, you incise, then there will be a fistula, milk fistula. Now, continuously she will be draining milk. So, it is benign, it doesn't pose any big problems. So, you wait, breastfeed the child, but if they are it creates a problem, then you have to suppress lactation with some drugs. Then you go for the operation. একটা ফোলা মানে কাটো, no. You have to wait. But a patient with lactation, but your FNAC report is giving fibroadenoma. It's a solid tumor, but benign. You just wait for 1.5 years or 2 years. Let the baby be breastfed, and then you go for the operation. The breast abscess. If it is not lactating, go for surgery. But if it's huge breast abscess, then you have to stop by drugs and then go do the surgery. But if it is in the point of bursting, then you have to make a small incision, let it drain, and then you manage accordingly. Now, extensive inflammatory abscess, this, it becomes huge, huge. The breast abscesses becomes huge. And see, this is the tuberculosis of the lymph nodes. Tuberculosis of the breast, this is the tuberculosis, see the big breast with secondary suppurating lymph nodes. If there are lymph nodes suppurating with a view, this thing, evening rise of temperature, you do a TB PCR study and also a final FNAC of the axillary lymph nodes. If it is tuberculosis, then you give medical treatment. It will be regressing and it will be okay. Now, subareolar abscess in duct ectasia. This is subareola. See, mammary fistula originating in a chronic subareolar abscess. Can be a chronic subareolar abscess. So you do a wider excision and drain and then manage by dressing. The bilateral duct ectasia with fistula. This is the fistula. Abscess is on the right here. Now galactocele. See, a galactocele can be this much cricket ball, and you see the huge galactocele. A 27-year-old multipara with progressive breast enlargement following confinement. Now, this is a picture from, most of the pictures are from Bailey and Love surgery. See, phyllodes tumor in a woman of 28 years is weight. Note the ulceration due to pressure. It should be possible to insert a probe freely between the skin and the tumor. Not so in carcinoma of the breast. Now this is a huge, it is non-malignant condition. So you can remove it. This is a enormous fungating carcinoma of the right breast with enlarged axillary lymph nodes. Lymphangiosarcoma developed 3 years after radical mastectomy. Patient well many years after 4/4 amputation of the upper limb. Now, these are trap flap. This is the plastic surgery, and these are the different types of breast prosthesis. External breast prosthesis. Now you can see carcinoma of the male breast. This is a male. Carcinoma of the male breast. Here, carcinoma of the male breast. And advanced carcinoma of the male breast. This. In London, Royal College of London Hospital. The chief Chengoi from a photograph by Mr. Situelot from Africa. This is the picture, litho cut picture. It's in old Bailey Loves. You can find this picture. Bailey Loves of surgery. Okay? You please, in the upper limb, breast and thorax, you please, there are 5 places: heart, your lung and breast. You please, you might be having a question in any form. It can be a short note, it can be a clinical presentation, and then what is this? Or then you get a 6 marks question. So don't ignore, it is a simple thing, and you please draw pictures, diagrams, whatever you call it, figures, you do it.